Okay. So you wanted to really understand diabetes medications without getting, totally lost in the weeds.
Yeah.
I think we've got some really great material for this.
I think so, too.
We've got audio from this pharmacology lecture. It was actually for dentists.
Interesting.
But it's super clear. And then we have this PDF that just kind of gives a really nice overview of all the medications.
Yeah.
So we're going to try to demystify all these different medications for diabetes.
Focusing on, what makes them different from each other and how they work.
Right, exactly. And you specifically mentioned that you wanted to know not just, what the medications are, but why.
Right. The why is so important.
Why are they used? And one of the things that I thought was interesting in one of our sources is they describe diabetes as like a story.
Oh, that's a nice way to think about it.
A problem with a cause, and then, importantly, a solution.
Yeah.
So we'll definitely be kind of following that story as we go through this and looking at how the body normally handles glucose.
Right.
And then where things go wrong in diabetes.
Yeah.
So let's just start with the basics.
Okay.
What is diabetes mellitus?
So in the most simple terms, it's when your blood sugar levels are too high.
Right.
But it's not just one single condition.
Okay.
There are actually different forms of diabetes. And our sources mention type 1, type 2 gestational diabetes, which is the kind that you can get when you're pregnant.
Right.
And then some rarer types as well.
Okay.
But I think for our discussion today, we'll focus mostly on type 1 and type 2.
Yeah.
Those are the most common ones.
Yeah, and that's what the lecture really focused on.
Right.
And they made a point to say that, usually different types of people get each type.
Yes, different demographic.
Yeah.
So type 1, you tend to see that in children and adolescents more often.
Yeah.
And then type 2 is more common in middle-aged and older adults. And we think that it's linked to certain lifestyle factors and having high blood sugar for a longer period of time.
Right. And so both of them have high blood sugar.
Yeah.
So what's actually the difference between the two in terms of what's going on in the body?
So at the heart of it, the problem is that glucose, which is sugar, which is our main source of energy, isn't getting from the bloodstream into the cells where it needs to be to provide that energy.
Right.
And the key to that process is a hormone called insulin.
Right.
And you can think of insulin like a key that unlocks the door to your cells so the glucose can get in and provide energy.
Okay, so in diabetes, something's wrong with either the key or the lock.
Exactly. That's a great way to think about it.
Okay, so let's take each type one at a time.
Yeah.
So in type 1, what's the problem with the key?
So in type 1 diabetes, the body basically stops producing the key, which is insulin. And this happens because the cells in the pancreas that make insulin, they're called beta cells.
Okay.
Those cells get destroyed. And the audio mentioned that it's often an autoimmune problem.
So the body is attacking itself.
That's exactly right. The body's own immune system is attacking those cells.
Wow.
And so because they're not producing any insulin on their own, people with type 1 need to get insulin from an external source.
Right.
Usually through injections or through a pump. Historically, this type was known as insulin-dependent diabetes or juvenile diabetes.
Okay.
Because you tend to see it more in children and adolescents, and usually the symptoms appear pretty suddenly, often before the age of 30.
Okay.
The important thing to remember here is that with type 1, the pancreas is just not making any insulin.
Okay.
And unfortunately, at this point, we don't have a way to prevent it or reverse it.
Okay. So that's a pretty fundamental problem.
Right.
So let's talk about type 2.
Okay.
How is type 2 different?
So it's more like the lock is becoming resistant to the key in type 2.
Okay.
So the pancreas can still make insulin, especially in the early stages, but the body cells, particularly in the muscles and in fat, they just don't respond as well to the insulin that is present.
Okay, so they're kind of ignoring it.
Yeah, it's almost like the lock is getting stiff and rusty and it's not opening as easily as it should.
Right.
And this, we think, is linked to genetics, sometimes aging, and lifestyle factors like obesity.
Okay.
Historically, this type was called non-insulin-dependent diabetes or adult-onset diabetes.
Okay.
And it tends to develop more slowly over time, usually after the age of 40. But what's important here is that the pancreas in type 2 is still making some insulin.
Okay.
And unlike type 1, there are things that people can do, like lifestyle changes, diet, and exercise that can help improve their sensitivity to insulin. And in some cases, they might even be able to reverse the condition if it's caught early enough.
That's great.
Yeah.
So the lecture talked about some common signs and symptoms for both types, and then some that are more specific. So what were some of the things that stood out to you?
Yeah, so some of the common ones include increased thirst and frequent urination.
And why is that?
Well, it's the body trying to flush out all that extra sugar. People might also experience unexplained weight loss even though they're feeling really hungry all the time. And they might have slow healing wounds, and they often just feel really tired because their cells aren't getting enough energy.
Right.
The audio also highlighted something called ketoacidosis as being more specific to type 1.
Okay.
Which is a dangerous condition that happens when the body starts to break down fat for energy because there's just not enough insulin to use glucose.
Okay.
And in type 2, nerve damage or neuropathy is more common over the long term.
Yeah.
But the big picture is that high blood sugar can have a negative impact on lots of different parts of the body.
Okay, so given all these differences, it makes sense that the goals of treatment would also be different.
Right.
For type 1 and type 2.
Yeah.
So what are the main things that doctors try to do when they're managing each type?
So for type 1, the main goals are to keep those blood sugar levels under control.
Okay.
Avoid that ketoacidosis at all costs. And maintain a good long-term average blood sugar level, which we measure using a test called HbA1c. And because people with type 1 aren't making any insulin, the main treatment is replacing that insulin with injections or a pump. Okay. For type 2, the goals are a little bit different. The main thing is to keep blood glucose levels in a healthy range. And then really importantly, prevent the long-term complications that can arise from having high blood sugar for many years.
Right.
And although lifestyle changes are really the cornerstone of treatment in type 2, a lot of people with type 2 will also need to take oral medications.
Okay.
And some people over time may also end up needing insulin.
Got it. So let's jump into the medications.
Okay.
The PDF that we have kind of groups them together, starting with the ones that are given under the skin.
Subcutaneously.
Yeah. So I guess the most obvious one when we're talking about diabetes is insulin itself.
Absolutely. As we said before, insulin is vital for people with type 1 to replace what's missing. And for people with type 2, it can help to overcome that insulin resistance or boost their own insulin production.
Okay.
And the interesting thing is there isn't just one type of insulin.
Okay.
There are different preparations that work at different speeds and for different lengths of time.
So the lecture did a really good job, I think, of breaking down these different types of insulin.
They did.
So there's rapid-acting insulins like Lispro, Aspart, and Gluazine. And those start working really quickly in less than 15 minutes.
Right. Think of those as the mealtime insulin.
Yeah.
If you're all to eat, you take the rapid-acting insulin.
Okay.
And then we have short-acting, which is regular insulin, which takes about 30 minutes to start working.
All right.
And there's intermediate-acting, which is NPH.
Okay.
That takes about 1 to 2 hours to kick in.
And then the long-acting.
Yeah, the long-acting ones.
Like Detamir and Glargine.
Right. Those have a slower onset, and they last much longer.
So those provide like a background level of insulin?
Exactly. It's like a basal level of insulin. They also mention ultra-long-acting insulins.
Yeah.
But those are less commonly needed for a basic understanding of insulin.
Right. And I thought it was interesting. Why do we need to know how quickly they start working and how long they last?
Well, that's really important for managing blood sugar levels effectively.
Okay.
Especially around meal times and throughout the day and night.
Okay.
It helps people to match their insulin dose to their food intake.
Got it.
And prevent both high and low blood sugar levels.
And so low blood sugar was mentioned as the most serious side effect of insulin.
Yeah, that's right. It's called hypoglycemia.
Right. Are there other side effects that people should be aware of?
Yeah, there are a few. So besides hypoglycemia, you might see weight gain.
Okay.
Sometimes people have reactions at the injection site.
Right.
And some people experience changes in the fat tissue under the skin at the injection site.
Okay.
Which is called lipodystrophy.
Lipodystrophy.
Yeah. And they mentioned that rotating the injection sites can help to minimize that.
Okay, that makes sense.
It's also important to remember that if someone has problems with their kidneys, their insulin dose might need to be adjusted. And our sources gave some target ranges for blood sugar.
Okay.
So a good average glucose level is around 154 milligrams per deciliter or lower.
Got it.
And an HbA1c of 7% or less.
Okay.
Just to give you some context, normal values are usually below 115 milligrams per deciliter for glucose.
Okay.
And under 5.7% for HbA1c.
Got it.
So that gives you kind of a baseline.
Yeah, that's good to know.
Yeah.
So the next one that's given under the skin was pramlintide.
Oh, yes, pramlintide.
And they called it an amylin analog.
Right.
And said that it's used along with Mealtime insulin.
Yeah.
So what is that all about?
This is where it gets really interesting.
Okay.
So pramlintide, it mimics this naturally occurring hormone called amylin,
Okay.
which the pancreas actually releases along with insulin after you eat.
Okay.
And pramlintide does a few things. It helps slow down the emptying of food from your stomach. It decreases the release of another hormone called glucagon after meals.
And what does glucagon do?
Glucagon actually raises blood sugar.
Oh, so that's helpful.
Yeah, so we want to suppress that.
Got it.
And it also makes you feel full, which is great for appetite control.
Okay.
But because of these effects, the dose of mealtime insulin often needs to be reduced by about half when someone starts taking pramlintide.
Oh, wow.
To avoid low blood sugar.
That makes sense.
Yeah. And it's given as an injection before meals.
Okay.
But there can be some side effects like nausea, loss of appetite, and vomiting.
Okay.
And it shouldn't be used in people who have a condition called gastroparesis.
And what is that?
That's where the stomach empties too slowly.
Oh.
So if it's already emptying too slowly, we don't want to slow it down even further.
Got it.
And another thing to remember is that it can't be mixed with insulin in the same syringe.
Okay.
They have to be given separately.
Got it. And then the third category
Yes.
of subcutaneous medications were incretin mimetics,
Oh.
which are also known as GLP-1 receptor agonists.
Right.
And these seem to work in a few different ways.
They do. They're really interesting medications.
Okay.
They essentially mimic the effects of a natural hormone called GLP-1,
Okay.
which is an incretin.
And what is an incretin?
So incretins are released from your gut when you eat.
Okay.
And they have several beneficial effects on blood sugar.
Okay.
So these GLP-1 receptor agonists help your pancreas release more insulin, specifically when your blood sugar is high.
Okay.
Which is a very clever mechanism
Yeah.
because it helps to avoid low blood sugar.
Right.
They also slow down the movement of food through your stomach.
Okay.
They reduce appetite. They decrease glucagon release after meals.
So all good things.
Yeah, all good things.
Okay.
And in some cases, they can even help the beta cells in the pancreas
Oh, wow.
to regenerate or function better.
So the overall effect is better control.
Better blood sugar control after meals and lower average blood sugar over time.
Got it.
Yeah.
Okay, so let's move on to the medications that are taken by mouth.
Okay.
So the first group here is sulfonylureas.
Right. Sulfonylureas.
And in the lecture, they describe these as working over the bump inside the pancreas.
Yeah, that's a good analogy.
Can you explain what that means? Like, how do they lower blood sugar?
So basically, sulfonylureas tell the pancreas to release more insulin.
Yeah.
And they do this by interacting with specific channels on the surface of those beta cells.
Okay.
So you can think of it like they're going in and stimulating those cells to pump out more insulin.
Okay.
And although there might be some other minor effects, like maybe reducing glucose production by the liver or making the body a little bit more sensitive to insulin, the main job of sulfonylureas is to increase insulin release from the pancreas.
So because they're increasing insulin, the main side effects are weight gain and low blood sugar.
Exactly. Those are the two big ones.
The lecture also mentioned being careful with these in people with liver or kidney problems.
Yeah, that's a very important point.
Why is that?
If the liver or kidneys aren't working properly,
Okay.
the sulfonylureas can build up in the body,
Okay.
and that increases the risk of blood sugar dropping too low.
Okay.
And one sulfonylurea in particular, glyburide, is known to be especially problematic for people with kidney issues.
Okay.
But there are others like glipizide and glympuride that are generally considered safer options for those with kidney problems and for older adults as well.
Okay, good to know. And then this is interesting.
Yeah.
Glyburide, they said, doesn't really cross the placenta very much.
Right.
So they said it might be an option for pregnant women.
Yeah, so it's a potential alternative to insulin for managing diabetes during pregnancy.
But I guess under close medical supervision.
Absolutely, always under close medical supervision.
Right. And they also mentioned that lots of other drugs can interact with sulfonylureas.
Yeah, drug interactions are really important to be aware of.
So some drugs can make them more effective, and some drugs can make them less effective.
Exactly. Some can reduce their effects, and others can potentiate them.
Right. Okay. Yeah. And they talk about the older first-generation sulfonylureas compared to the newer ones.
The second-generation ones, which are more potent.
Right. Okay. So next up, we have metformin.
Metformin.
Which is a bigranide.
Yes.
And this one was actually called the first-line drug for type 2 diabetes by the ADA.
That's right, the American Diabetes Association.
Right, and it seems to work totally differently than the sulfonylureas.
It does. It has a completely different mechanism.
Okay.
So metformin primarily works by reducing how much glucose the liver produces.
Okay.
It also helps to slow down the absorption of sugar from the intestines.
Okay.
And it improves how the body's cells use insulin.
So it's making them more sensitive.
Exactly. It's improving insulin sensitivity.
Okay.
And unlike sulfonylureas, metformin doesn't directly tell the pancreas to make more insulin.
Okay.
And it can even sometimes lead to a little bit of weight loss, possibly by decreasing appetite. Yeah. So because it works in these ways, the risk of low blood sugar is generally lower when metformin is used on its own.
Okay.
But if it's taken with insulin or a medication like a sulfonylurea that does increase insulin production,
right,
it can increase the risk of low blood sugar. So doctors need to be really careful with the doses.
Okay.
And monitor patients closely.
Got it. So with metformin, the main side effects that they mentioned were gastrointestinal issues.
Yeah, like nausea, diarrhea, things like that.
Right. And they said it shouldn't be used in people with kidney problems because of the risk of lactic acidosis.
Right. Lactic acidosis is a very serious condition.
Yeah.
And it's rare, but it can happen in people with kidney problems who are taking metformin. Yeah. So it's really important to avoid it in those cases.
They also said that it should be stopped for a while in situations like a heart attack.
Yeah, or if someone's heart failure gets worse.
Right.
Or if they have a severe infection.
Because their kidneys might not be working as well.
Exactly. In those situations, kidney function can decline really rapidly.
Okay. And they said to use it cautiously in older adults, people with heart failure, and people who drink a lot of alcohol.
Right. Those are all important considerations.
And then one other thing they said was that long-term use of metformin can interfere with vitamin B12 absorption.
Yeah. So that's something to keep in mind.
Okay. So moving on to thiazolidinediones.
Thiazolidinediones.
Are TZDs.
TZDs, yeah.
So the main examples are pioglitazone and rosiglitazone.
Right.
And these are also insulin sensitizers.
Yes, they are.
So how are they helping the body use insulin better?
So TZDs work by making the body's tissues like fat, liver, and muscle more responsive to insulin.
Okay.
And they do this by activating a specific receptor inside the cells that helps regulate genes involved in glucose and fat metabolism.
Okay.
So they need some insulin to be present to work.
Okay.
But they don't directly cause the pancreas to make more insulin.
Okay, so they're working more downstream.
Exactly. They're working more at the level of the tissues.
Got it.
And they can also have some effects on cholesterol levels. So both pioglitazone and rosiglitazone can increase HDL cholesterol, which is the good cholesterol.
Okay, that's good.
But rosiglitazone can also increase LDL cholesterol and triglycerides.
Which are bad.
Yeah, those are the ones we want to keep low.
Okay.
Whereas pioglitazone tends to lower triglycerides.
Okay, so that's a good thing.
Yeah.
So they can be used on their own or with other medications.
Right.
And pioglitazone is often considered a second or third line option for type 2.
Yeah, that's right.
But rosiglitazone is used less often because of those concerns about heart problems.
Yeah, that's a major concern with rosiglitazone.
And the side effects for these sounded pretty serious.
They can be. There's liver problems,
Yep.
weight gain from fluid retention.
Right.
And then there's the specific worries about heart problems with rosiglitazone.
Right.
And a possible link to bladder cancer with pioglitazone.
Yes, so doctors have to be really careful when they're prescribing these.
Absolutely. They have to weigh the risks and benefits very carefully.
So what are some of the things they need to watch out for?
So regular liver function tests are really important.
Okay.
And they should not be used in people with severe heart failure.
Okay.
And then the association of rosiglitazone with heart attacks and strokes.
Right.
And the possible increased risk of bladder cancer with pioglitazone. Those are all things that doctors really need to consider.
Okay. And rosiglitazone also has that risk of bone thinning and fractures.
Right.
Yeah.
Yeah, so it's a less favorable option overall.
Okay. Next we have the alpha-glucosidase inhibitors.
Alpha-glucosidase inhibitors.
Like acarbose and miglitol.
Mm-hmm.
And these work right in the gut.
Yes, they do.
To slow down the digestion of carbs.
Exactly. They work directly in the small intestine.
Okay.
To delay the breakdown of complex carbohydrates into simple sugar.
Okay.
That the body can absorb.
Got it.
And they do this by blocking enzymes called alpha-glucosidases.
Okay.
So by slowing down that process, they help to reduce the spike in blood sugar that happens after a meal.
Okay.
And because they don't affect insulin release.
Right.
Or insulin sensitivity.
Mm-hmm.
They don't usually cause low blood sugar
Okay.
when used alone.
But because they're working in the gut, the main side effects are diarrhea and abdominal cramping.
Yeah, that's right. Those are the most common ones.
And they shouldn't be used in people with certain bowel conditions.
Right, like inflammatory bowel disease or intestinal obstruction.
Right. Okay, then we have the DPP-4 inhibitors.
DPP-4 inhibitors, yeah.
Often called the gliptins.
The gliptins, right.
So there's allagliptin, linagliptin, saxagliptin, sitagliptin.
Yeah, they all have that gliptin at the end.
Yeah, and these are making certain hormones last longer in the body.
Exactly. So they inhibit an enzyme called dipeptidyl peptidase 4, or DPP-4.
DPP-4.
And this enzyme normally breaks down incretin hormones.
Okay.
Like GLP-1 that we talked about before.
Right.
So by blocking this enzyme DPP-4, the gliptins allow these incretin hormones to hang around in the body longer and have more of an effect.
So more insulin release.
More insulin release in response to meals and less glucagon. Which helps to lower blood sugar.
So all good things.
Yeah, all good things.
Okay, and these can be used alone or in combination.
Right. They can be used as monotherapy or in combination with other diabetes medications, including insulin.
Okay, great. And then finally we have the SGLT2 inhibitors.
SGLT2 inhibitors.
Which are called the flozins.
The flozins, yeah.
Like canagliflozin and dapagliflozin.
Right.
And their mechanism is really interesting.
It is. It's very unique.
Yeah, because they work in the kidneys to get rid of extra glucose.
That's right. They're working directly in the kidneys.
Wow.
And they target a protein called sodium glucose cotransporter 2.
Or
SGLT2 for short.
SGLT2.
And this protein is responsible for reabsorbing glucose back into the bloodstream as blood is being filtered through the kidneys. So by blocking this transporter, these medications cause more glucose to be excreted in the urine.
Oh, wow.
Which lowers blood sugar levels. And as a side effect, they also increase sodium excretion, which can sometimes lead to a slightly lower blood pressure. But the main purpose of these medications is to control blood sugar. The most common side effects are urinary tract infections and more frequent urination.
Which makes sense.
Because of all that extra glucose in the urine. And there can also be a risk of low blood pressure, especially in older adults or people taking diuretics.
Okay, so that's a lot of different medications.
It is a whole range of medications.
Yeah, with really different ways of working.
Yeah.
And it just shows how complex managing diabetes can be.
It really does. There's no one-size-fits-all approach.
Yeah.
And it's really important to understand all the different options.
Right, and all the different side effects.
Absolutely.
So we can categorize these medications, I guess, based on how they work.
Yeah, that's a helpful way to think about them.
So we have the ones that help the body produce more insulin.
Right, like sulfonylureas, GLP-1 agonists, and DPP-4 inhibitors.
Okay, and then the ones that improve the body's sensitivity to insulin.
Right, like metformin and the TZDs.
And then we have the others like pramlintide.
Yeah, pramlintide's kind of in a category of its own.
Right.
Affecting stomach emptying and glucagon.
Right, and alpha-glucosinase inhibitors that slow down glucose absorption. And SGLT2 inhibitors that increase glucose removal by the kidneys.
Exactly.
So we covered a lot of ground today.
We did.
So just to wrap up.
Okay.
We talked about the basics of diabetes.
Right.
The key differences between type 1 and type 2. And then all these different classes of medications that are used to manage them.
Yeah.
So you should now have a much clearer understanding of how these medications work.
Hopefully.
Their main targets, whether it's the pancreas, the liver profile, tissues, kidneys, or the gut.
Right. Different medications work in different places.
And some important things to consider, like side effects, and when these medications might not be appropriate. So hopefully this has made the whole story of diabetes and its treatment a little less overwhelming and a lot more understandable.
That was the goal.
Yeah, and so I was thinking about what you were saying about how these medications work in different ways.
Yeah.
And it made me think, are there other conditions in the body that might benefit from treatments that target these same pathways?
It's a great question.
Yeah, like maybe metabolic syndrome.
Yeah.
Or even aging.
Yeah, potentially. It's really interesting to think about.
Yeah, so it really highlights how interconnected all the systems in our body are.
It does. It's all one big system.
So this has been a really high-level overview, obviously.
Yeah.
And each of these classes of medications has its own whole world of, research and ongoing development.
Absolutely. It's a constantly evolving field.
So we encourage you to kind of go out and explore any of these areas that you're interested in.
Do your own research.
What questions do you still have about specific medications or their long-term effects? This is just the beginning of the story.
Exactly.
So keep learning.
Keep learning.